مساء النور لكل الزملاء والأصدقاء بلبنان وبالمشرق العربي وبأوروبا، وبنفس الوقت صباح النور لكل الزملاء اللي عم بيتابعونا من أمريكا الشمالية وأمريكا الجنوبية، وخاصة من أستراليا وقت بنعرف أنه بهالوقت بملبون الساعة 4 الصبح. رح أطلب من البروفيسور شرف أبو شرف نقيب أطباء لبنان ببيروت انه يفتتح هيدي الحلقه الافتراضيه التثقيفيه الثانيه اللي هي من مسلسل حلقات عم بتنظمه الجمعيه الطبيه العالميه واللي هو مخصص اليوم لامراض وجراحه الانف والاذن والحنجره. دكتور شرف الكلمه لحضرتك.
أنا كمان بدي جدد شكري لكم الصراحة على هالمبادرات العلمية القيمة اللي عم تقوموا فيها، واللي هي عم تعطينا ضوء بهالعتمة اللي عايشينها بلبنان. الضوء كل عمره بلبنان ما بيجي إلا عن طريق العلم، وانتم عم ومنها
صوت دكتور بروفيسور شرف.
في عنا مشكلة بس
I think Professor Sharaf needs to unmute. Yep.
هلا أحسن.
ايه هلا أحسن.
دونك بجدد شكري لكم بالدولة بالإلما على هالنشاطات العلمية يلي عم بتساعدنا حتى نضل up to date شو عم بيصير رغم كل المشاكل اللي عم نعاني منها بلبنان. عم تعطونا نفحة أمل ونور هالظلم اللي عايشينها، ولبنان كل عمره اتكاله بدأ يقول العلم وأهل العلم حتى يتقدم. دونك بشكركم وبشكر دكتور وليد رئيس المنظمة أو المؤسسة، وبتأمل إنه نقدر نضل نكون مثل ما لازم حتى نضل على المستوى اللي عدناه، وبكتفي بهالشيء هيدا.
ميرسي بريزيدان دكتور شرف على هالمبادرة وعلى هالتشجيع. بدي اتوجه لدكتور وليد أحمر اللي هو رئيس الجمعية الطبية اللبنانية العالمية اللي راح يفتتح كمان هيدي الحلقة الثانية من مسلسل الحلقات التثقيفية العلمية. دكتور وليد.
بشكرك دكتور يوسف. تنحكي بالإنجليزية. Good evening on behalf of the International Lebanese Medical Association or ILMA. I want to welcome all our Lebanese physicians, health professionals and students, both within Lebanon and throughout the world, to the second update or educational series in collaboration with the Lebanese Order of Physicians. The topic tonight is updates and innovations in otolaryngology, head and neck surgery. We are excited by our collaboration with the Lebanese Order of Physicians in these educational webinar series. We want to partner with our Lebanese colleagues to advance our knowledge base and to establish collaborative medical partnerships, including in education and research. ILMA wants to bring the best of the international world of medicine to Lebanon. It is important as physicians that we enhance our knowledge base, not only for our continued development as physicians, but also in advancing the best level of care to our patients. We can all learn from each other. I want to thank Dr. Sharaf Abi Sharaf, the President of the Lebanese Order of Physicians, for his wonderful efforts in supporting this educational webinar series. I also want to thank Dr. Yusuf Bakhosh and the ILMA LOP Education Committee for working to bring this second webinar together. I will leave Dr. Bakhosh to introduce our next speaker.
Thank you وليد. اسمحوا لي بمناسبة هيدي الحلقة الثانية واللي هي والأذن والحنجرة. بتوجه بالشكر لكل الأشخاص اللي ساهموا بتنظيم هذه الحلقات التثقيفية والافتراضية، إن كان من داخل لبنان وخاصة نقابة الأطباء واللجنة العلمية ولجنة التثقيف الطبي المستمر، أو من خارج لبنان وخاصة الجمعية اللبنانية العالمية الطبية وأفراد هن أو أطباء أو من متحضرين من أصول لبنانية. بدي أتشكرهم على كل جهودهم اللي عم بيبذلوها لإنجاح هذا المشروع ولاستمراريته. إنه من 3 أسابيع كان عندنا الحلقة الأولى وكانت مخصصة لجائحة كورونا ومنظمة مع الجمعية اللبنانية للأمراض الجرثومية، وهيدي الحلقة اتكللت بنجاح كتير كبير، وخاصة لأنه المحاضرين كانوا ذوي مستوى علمي كتير رفيع، والمحاضرات والأبحاث اللي قدموها وناقشوها كانت فعلا قيمة مضافة لكل الحضور اللي تخطى العدد اللي كنا نحن متوقعينه. وهلأ اسمحوا لي أنه أعطي الكلام للبروفيسور مصطفى سويدان اللي هو أخصائي ورئيس قسم جراحة الأنف والأذن والحنجرة في مستشفى الزهراء الجامعي ببيروت. دكتور سويدان هو رئيس الجمعية اللبنانية Lebanese Society of Otolaryngology Head and Neck Surgery. دكتور سويدان الكلام لحضرتكم. Can you unmute Dr. Mustafa Swaydan, please?
Good afternoon. مساء الخير. حضرة طبيب أطباء لبنان البروفيسور شرف أبو شرف المحترم، حضرة رئيس جمعية إلما دكتور وليد أحمر محترم، حضرة البروفيسور يوسف بخاش رئيس دائرة CME بالنقابة أطباء لبنان، زميلاتي زملائي، يسرني أن أكون معكم في هذه الأمسية العلمية التي نعمل من خلالها على إبقاء قنوات التواصل والاتصال مع مختلف الجمعيات حول العالم، وذلك للحفاظ على المستوى العلمي ومواكبة تطوراته وأبحاثه، لا سيما وأننا في السنتين الماضيتين كان هناك شبه انقطاع بسبب جائحة كورونا حول العالم وما زالت ترخي بظلالها هذه من جهة، ومن جهة ثانية نحن في لبنان لدينا جائحتين، جائحة صحية تعني بالكورونا واجتماعية اقتصادية، أدت هاتين المشكلتين إلى هجرة عدد كبير من زملائنا، وذلك بحثا عن مستوى معيشي أفضل. ومن هنا كان لابد وأن نعمل على تأمين مقومات الصمود لما تبقى لجهة الدعم العلمي والأكاديمي، وقد يكون هناك دعم اقتصادي لاحقا عن طريق نقابتنا لسن القوانين التي تحفظ حقوق الجميع، ونسعى إلى أن نعيد من هاجر قريبا إلى الوطن لمواكبة التطور العلمي الذي كان منارة لبنان وسيبقى إن شاء الله. أكرر شكري للجميع وخاصة بروفيسور بخاش على هذا العمل الذي سوف يتابع، وإن شاء الله إلى لقاء قريب.
دكتور سويدان، أنا بدي أتشكرك على هذه الكلمة وكل الجهود اللي حطيتها لحتى نقدر ننجح وننظم هذه الحلقة المخصصة لأمراض وجراحة الأنف والأذن والحنجرة. وهلأ رح نعطي الكلام for the two moderators، يعني دكتور فرانسوا أبي فاضل ودكتور عمر مطران to start the scientific sessions.
Thank you, Dr. Yusuf. I would like to introduce our two moderators with us tonight. Firstly, a dear friend of mine, Dr. Francois Abifodil, who is a physician in pulmonary and critical care medicine. He's a medical director of respiratory therapy and pulmonary rehabilitation, and an associate professor of clinical medicine at the Cleveland Clinic in Ohio. And our second moderator is Dr. Homer Matron, who is an associate professor and director of otolaryngology, head and neck surgery at Staten Island University Hospital in New York City. He's also an assistant professor at Hofstra University. He also sits on the board of governors of the American Academy of Otolaryngology, Head and Neck Surgery as a consultant. I'll leave the floor to you, Francois, and to Homer now.
Okay, thank you so much, Walid. And thank you, Dr. Yusuf Bakhash, for this opportunity to be with you today and to be one of the moderators for this presentation. I'm going to let Dr. Mutran take it from here to introduce our first speaker, and then both Dr. Mutran and myself will be taking questions from the audience. I'm going to ask the audience, please, if you have any questions, to place those in the chat box, or at the end of the talk, we can take 5 minutes to have questions.
Again, with you folks, as you have seen.
It's up to you.
Okay, thank you, Francois, and I'm glad to be here. Thank you, Dr. Bakhash, the Lebanese Order of Physicians, and ILMA for putting together this beautiful crowd. So our first speaker is Professor George Fayyad. It is my privilege to present him as a former governor of the International College of Surgeons. He is the chairman of ENT at Basildon University Hospital and the consultant in private practice, both in London. His expertise covers cutting-edge technologies in treating issues of breathing, sinuses, balance disorders, and cosmetic surgery. He treats everyone from newborn to grandparents. We actually need a whole session to mention all of his achievements and his distinction titles. Today, Professor Fayyad will be talking about vertigo and balance from an ENT perspective. Dr. Fayyad.
Thank you very much, sir. Thank you. That's very kind of you. I don't know if I deserve all this, introduction, but anyway, it's my pleasure to be here. I would like to, of course, thank Professor Sharaf, Dr. Ahmar, Dr. Bakhash, and everyone else, including you, my dear colleague, in ENT. I am in principle a rhinologist, and when Dr. Ahmar asked me to talk about vertigo, I thought, it came to my mind when we were in years gone, and someone asked us to explain the problem of Lebanon, political problem in Lebanon of Lebanon, in 1 hour. And little did I know that Dr. Bakhash Dr. Ahmar only gave me 15 minutes to talk about this vertigo subject. So I'll try to do my best, and I've prepared my slides, in a hurry, and I try to tell you in 15 minutes, particularly for those who are not ENT specialists, what's the ENT perspective about, this problem. I don't know if you can see my screen now. Can someone please tell me if you're able to see my screen?
Not yet, Dr. Fayyad. If you're able to share your screen, please.
Sorry about that. Just bear with me 1 second. Can you see it now?
Yes, we can see it.
Okay, very good. So I'll start to tell you that not only in vertigo, but in all fields. Can you see the full slide? Because I cannot see it from my side.
We're able to see the full slides, yes.
Okay, very good. Thank you. So essentially, I'll try to, in 15 minutes, to summarize the ENT perspective when it comes to vertigo and imbalance problems. Patients tend to amalgamate all these symptoms. They will tell you that they suffer from vertigo, dizziness, imbalance, disequilibrium, muzzy head, fuzzy head, and you name it. There is a whole series of terms that the patient will use to explain to you their suffering. And sometimes they will explain it in a way that it puzzles the doctor more than anyone else. And some of our colleagues tend to try to escape through a window when these patients come to their clinic. And the problem is quite significant because if you look at yourself and around you, you probably have experienced some kind of vertigo or dizziness at some point in your life. If not yourself as a person, someone in your immediate family. And I'm not talking about a professional, your patients. I'm talking about your immediate family. So the problem is really quite serious and quite significant. Of course, there are quite a few possible causes for the problem, both otological and non-otological. And we in ENT tend to receive all those patients that can be referred to us from any kind of other discipline, other specialty, that they don't want to deal with these patients because they find it always quite challenging and difficult to diagnose and to treat those patients. So it can be very challenging because patients tend to give a very vague history. And the more you try to understand the problem sometimes, the more you get confused yourself. And then you start asking yourself, what kind of clinical examination should I do? Apart from a basic neurological exam, any NT examination, audiovestibular testing, imaging, you name it. Because of course you want to understand the etiology before you can offer a treatment to those patients. And the treatment can indeed be simply reassurance and counseling. It could be medical, pharmacological, it could be physical therapy, or even surgery in some instances. So it's very important in this instance to re-insist about the history. Taking history and anamnesis in these patients is extremely important. However, I always warn my registrar, my trainees, that they shouldn't do it too much. It's one of these subjects that the more history you take, sometimes you feel that the more confused you are. And there is a point that is optimal in history taken in these patients. And you should really be careful not to take too much information. And this is probably the only category of patients in medicine that you really don't need to take too much information and history. So just for a reminder for those of you that don't deal with these patients, they are lucky enough not to see any of those. So we have three sensors in the body, three systems of sensing of the environment and movement, which are the inner ear, the eyes, and these tiny springs that are nerves under the skin. They feed the brain with information on a permanent basis, and the brain, like a computer, will process this information and it will give orders to the eyes and to all muscles in the body for it to maintain a stable position. Luckily, this system has one important characteristic, is that it is redundant. So if you are sitting on a chair like me right now, if I close my eyes, I wouldn't fall off the chair, because obviously I don't rely only on my vision to maintain my balance. The other characteristic of this system is that, like blood groups, some of us rely essentially on the inner ear for their balance, some others rely essentially on the vision, and some others more on these tiny springs, the somatosensory system. So when we see those patients and we want to take history, I mean, like in many situations, history can lead us to a diagnostic in about 80–85% of the cases, and in this kind of patients even more, perhaps. So dizziness, it's like flavors. When you see a patient sitting in front of you and they start giving you the history, you yourself, you should start using your own senses to try to determine what category of problem we're talking about. So you have these patients that talk about, feeling that they want to faint. Some others that they have gait problems more than anything else. They are in constant disequilibrium. Some others that have real vertigo and they tell you the room is spinning or the floor is not even. And those that are psychogenic, and those are easy to determine because these patients, they usually come with an extremely long list of problems. They'll tell you, oh, by the way, my eyes are hurting, and my neck is hurting, and my shoulder is hurting, and my stomach has been bubbling, and so forth. So, and it's very important, you as a doctor seeing these patients, to open your eyes and ears and all your senses to try to sense what kind of patients we are talking about. The trajectory of the disease is extremely important. So there is perhaps no other pathology that timeline is very, very important. So you have those patients that tell you, my symptoms have been very severe and they lasted 3–4 days and that was it. and I became fine. Those who have recurrent episodes of dizziness or imbalance, with long periods of remission, and there are different patterns, and this is an extremely important point when you want to diagnose these patients. And we try for the dizzy patient to put them in a matrix, and because we are ENT surgeons, we want to test the hearing, do an audiometric. It's very easy, audiometric testing, and to determine whether the problem is an inner ear problem or not an ear problem. And for example, in BPPV, they don't have a hearing loss. In Meniere, they have a hearing loss on lower frequencies. So we try to classify those patients according to the characteristic of the vertigo and the hearing loss. Obviously, now we tend to think that equilibrium and balance are more like a 6th or 7th sense, as opposed to it's like a vision or taste, or it's literally a sense that tends to decline as we age and as we grow older. So like we have presbycusis, we have probably something called presbybalance, and these patients have multifactorial symptoms, and it's typical, those patients typically have a point in their history that has caused the symptoms to appear suddenly. So for example, you have the elderly lady on a wheelchair that has had her hip done recently, and usually they come to your clinic with angry members of the family with them, and this is typical of the multifactorial disequilibrium of aging. Of course, migraine is a big issue. Migraine is a obviously very, very common problem, and it can cause dizziness. Vestibular migraine is a very well-defined entity, and nowadays we tend to think that in actual fact, Meniere's disease is some sort of migraine-associated dizziness. In the past, we used to dissociate Meniere's from migraine-associated dizziness, and of late, we tend to think that the two are really associated. So the progressive disequilibrium of aging is a gradual decline, like any of the senses, and it's very, very important to bear in mind. The migraine, like I said, is a very important entity. Those patients typically have motion sickness, and they, as children, they would have given symptoms of migraine, tummy ache, and they keep having these episodes of migraine, and they tend to be dizzy. Because my partner is a neurologist, and I remember a few years back, I tended to tell her, migraine doesn't exist. There's nothing that's called migraine. And more recently, I started to discuss with her, and migraine is not anymore the entity that maybe all of us studied in our textbooks, with the pain, in presentation, photophobia, etc. Migraine can be triggered in open spaces, and sometimes we tend to put those migraine episodes leading to dizziness and confuse them with agoraphobia. And it's very important to dissociate the two. I'm not looking at my watch, but I hope that I'm not overrunning. But anyway, so and it's very important to.
We're still good. We're still good.
Okay, good. So this kind of, this presentation is very important, in particular for non-ENT. And yeah, it's very important to be able to identify, those patients with migraine. Of course, the risk factors are family history of migraine, and motion sickness gives away normally this migraine-associated dizziness. All these patients, or most of them, if you ask them, they will have somehow, somewhere, a problem of motion sickness. And again, I cannot stress enough the association between migraine and Meniere's disease. The two can, the limit between the two is very blurred, and we are often be talking about the same condition. I'm running through these slides very quickly just to talk about the cervical vertigo, which is a very important entity. And nowadays, with people sitting on computers and holding mobile phones, many of them are developing neck problems. On top of those who have suffered from a whiplash injury. And so we are seeing more and more of these patients in everyday clinic. They essentially complain of a whirling sensation. It's literally if they're being put in a tumble dryer. This is the way they describe it. And usually if they change position, for example, they've been sitting for some time and stand up very quickly. And it's always essential to bear this in mind as and to not to hesitate to send those patients to have imaging of the cervical spine. And send them sometimes to the rheumatologist or for some physio can be extremely helpful to them. So yeah, essentially this is, nowadays we are seeing a lot of these patients. So just a quick reminder, the history is extremely important. Timeline is very, very important. Triggers, in particular when it comes to migraine. As you know, a migraine can have very, strong triggers, caffeine, cheese, you name it, many things. And it's the same for some migraine-related vestibular issues. So the duration of the episodes is extremely important in order to determine what kind of entity we're talking about. And as usual, it's always essential, and any ENT surgeon must be able to carry out a very good basic neurological exam in order to rule out central problems in those patients. And always remember the change in position for BPPV and also for cervical problems, cervical disease, the swirling sensation, which is extremely important to bear in mind. I'll very quickly, discuss clinical cases, clinical presentation. So this is a 28-year-old female, intense spinning on getting up in the morning. Many patients will tell you about having episodes of very severe dizziness when they get up, the first thing when they wake up and getting up from bed. No hearing loss on examination. The tympanic membranes within normal limits, left beating nystagmus, basic neurological exam within normal limits, and no neurological deficit on examination. So here we'll be talking, of course, of either a problem of vestibulitis or vestibulitis, or of course we have to bear BPPV in mind. Vestibular rehabilitation is extremely important in many situations for these patients because it will hone your balance system very quickly and get you back on your feet. This is another case of a 41-year-old male.
Interrupt, Dr. Fayyad. We have another minute and a half to 2 minutes.
Yeah, okay, it's fine.
So we would allow for questions.
Okay, well, I think I'll pass on those ones. Just to see what do I have. Neurological order, findings, BPPV, Dix Holbike. Well, I'm going to pass on all those. Just to go the summary then. And again, just to repeat, the first thing you want to do is open, in your history taking, you have to immediately have a flavor nearly in your mouth and say, well, this is what I'm talking about here. BPPV is Meniere's, is migraine. This is something that you have to be able to do from the history. Even the nervous patient, psychosomatic, etc., you have to be able to detect them from the history. The trajectory and timeline is extremely important. in this kind of pathology when you are taking history. The matrix, remember the hearing loss, especially from an ENT point of view, the hearing test is very important when we know what we do in clinic. The migraine is extremely important, cervical problems, and of course, bear in mind always rare neurological problems and never hesitate to call other specialists in neurology, rheumatology, etc. Thank you very much for your time, and it was a pleasure to talk to you.
Thank you, Professor Fayyad. Very interesting and globalistic approach to dizziness. And as you said, we all kind of get anxious when we see a patient with migraine because sometimes they have a very weird presentation that is not always directly coming from the book, I would say. So before I allow someone else to ask a question, I have a quick question about migraine. Classically, ENTs used to send these vestibular migraine patients to the neurologist to do the treatment, but we are seeing kind of a little shift in that paradigm. For example, at the American Academy meeting of this year, there was a whole stand of the American Migraine Association they're kind of catering the information to the ENTs, and I subscribed and they sent me all the material to start the treatment as, at least as a first line of treatment to vestibular migraine, even without sending to neurology. So what do you think about that approach in your experience?
Yeah, well, first of all, I'm sorry I missed the meeting in Los Angeles this year, thanks to COVID, because I usually attend every year and it's very, very good meeting. Well, I mean, obviously, we have different healthcare systems and everyone does slightly differently, and not necessarily because of guidelines or good science and good medicine, because the healthcare system is designed in a way that incites you to refer earlier. Sorry. So what I was going to say is that in England, at least, and I'm lucky in that I have the experience in England and also in Belgium, as it happens, we tend to refer to neurology very early on. Now, this category of patients, as you know, Dr. Matran, every specialty, they want to lumber them on other specialists because they are quite difficult to treat, and treatment is not always very rewarding. So we tend to refer when we come up with a diagnostic, and for example, for typical menhirs with the calorics, positive tests, and the audiology in line with menhir, I tend to treat them myself. Now, those patients that are on the other end of the spectrum and they are more migraine, I tend to refer them to neurology early on.
Thank you, Dr. Fayyad. Anyone else has a question to Dr. Fayyad? All right, so I think we're going to move to the next speaker, Francois.
All right, thank you, Omer. So thank you, Dr. Fayyad, for your talk today and for being with us. Our next speaker is Dr. Alexandre Hammam. Dr. Hammam is an otolaryngologist, cervical and facial surgery specialist from Germany Hospital in Oswaldo Cruz in Sao Paulo in Brazil. He's also the president of the Lebanese Brazilian Otolaryngology Association. Dr. Hammam, are you with us?
Yes, can you hear me?
Yes, we can hear you.
Okay.
The platform is yours, doctor.
Okay, I'll share my screen.
Go ahead, please.
Well, first of all, I would like to thank ILMA and Dr. Walid Ahmad for the invitation and say that's a great honor for me to represent Brazil in this meeting. My name is Alexander Hammam, and I've been an otolaryngologist for 36 years, and I work in a German hospital, Oswaldo Cruz in São Paulo. This hospital was founded in September 26, 1897 by a group of German German-speaking immigrants, led by Consul of Germany at this time, Anton Zerener. There are 350 beds, 22 operating rooms, 96,000 square meters to build in that area. And there is a Faculty of Education in Health Science and Technical School of Health Education. This is me on the left and my wife on the right. She is a dentist, in the middle, my anesthesiologist, Dr. Max. We are a big team. But let's talk about sinusitis and odontogenic sinusitis. In 2018 survey in the United States, nearly 29 million people had sinusitis, equivalent to 11% of adults, according to the National Center of Health Statistics. These 29 million people have chronic rhinosinusitis, 11% adults, and 4.1 million office visits, and 234,000 visits on the ER each year in this year. But let's make a definition of sinusitis odontogenic. Is a presence of nasosinusal disease in which radiographic, microbiological, and or clinical evidence indicates a dental origin. It corresponds to 10 to 40% of cases of sinusitis. More than 5 million implants are placed each year in the United States, according to the American Dental Association. Recent literature suggests that increasing rates of dental surgery in recent years may be associated with increased incidence of iatrogenic causes of sinusitis in the United States. Although the overall incidence of odontogenic sinusitis remain relatively low, several studies have shown that the incidence of odontogenic sinusitis appear to be increased in the last decade in the United Kingdom. Odontogenic sinusitis is more common between 40 and 60 years old, and slight predominance of women. About 50% of patients will report prior dental surgery or infection. However, only a third will report associated tooth pain. It's estimated that 10% of cases of chronic maxillary sinusitis are odontogenic origin. Although it has been reported that it can reach 75% among patients with unilateral maxillary disease. Etiology. Iatrogenic dental procedures like tooth extraction, maxillary dental implant placement, sinus augmentation grafts, sinus lift, misplaced foreign bodies, orthodontic and cleft palate surgery procedures have all been associated with odontogenic sinusitis. Dental diseases, periodontal diseases, and periapical diseases. Other diseases, maxillary bone trauma, and odontogenic cysts, neoplasms, or other inflammatory process. This is an interesting review of 647 cases of odontogenic sinusitis. Etiology, iatrogenic, 65.7% of cases. Apical pathology, 25.1% of cases, and periodontitis, 8.43% of cases. The most commonly affected teeth. This is the first molar, this one, and second molar, 22%, third molar, 17.4%, and the second premolar, Symptoms. The symptoms could be facial pain or pressure in the face, postnasal drip, nasal congestion, purulent anterior rhinorrhea, which may be unilateral, cacosmia, halitosis, and unpleasant taste, dental procedure history. Important notes. Dental pain is often absent from odontogenic sinusitis. When present, in the absence of other nasal symptoms, it's not specific for sinusitis. Latency period. Latency period is of up 1 year. Careful evaluation dentition for tooth fractures, dental pulp status, periodontal tissues, and presence of oral antral fistula. And the condition of existing dental restorations are important components in the initial physical examination. We need to examine the teeth of the patients, not only ear, nose, and throat. We must start to examine the teeth too. Diagnosis. We do a nasofibroscopy and see purulent secretion in the middle. CT scan with cone beam, panoramic, and periapical. Microbiology or bacteriology. It's important to know that bacteriology of odontogenic sinusitis is different from non-odontogenic sinusitis. Odontogenic sinus infections are generally polymicrobial and predominantly anaerobic organisms present in culture, commonly including Streptococcus, Prevotella, and Fusobacterium. This is an interesting paper with 121 cases with surgical intervention. Zirk et al. 121 cases, 70% are anaerobic and 30% are aerobic. The treatment, sensibility, piperacillin and amoxicillin combined with lactamase inhibitor like clavulanate, following by cefotaxime. If the patients are allergic to penicillin and derivatives, ciprofloxacin and moxifloxacin are indicated. The treatment obviously depends on the case. Obviously, it must be dental isolated or combined root, nasal and dental video endoscopy, or only nasal endoscopy video. It depends of the case. Now, our experience are 97 cases, 89 after implant, 6 after bone graft, and 5 periapical disease. This is not a Brazilian statistic, it's our statistics in our group. But there is a bias because some dentists send the patients to us. So this is not a statistic from Brazil, it's our group only. This is one case, the tooth root is inside the maxillary sinus. This is bone graft contaminated with the maxillary sinus. This is only a bone graft. This is the implant inside the maxillary sinus, totally inside. And this is an implant contaminated maxillary sinus and ethmoid sinus and frontal sinus. It's a great complication. That's all. Thank you. Shukran.
All right, Dr. Hammam, thank you so much for your talk. I'll ask the audience, please, to, if anybody has any questions, to unmute and ask the questions for Dr. Hammam. We have a question from the chat box from Dr. Sharbil Talani. It says, when I started my ENT residency 10 years ago, we used to do a lot of sinus maxillary punctures. Now it has become quite rare. Do you still do punctures often in Brazil? Dr. Talani is a head and neck surgeon asking the question. Dr. Hammam?
Yeah.
So the question from Dr. Telani is, do you perform a lot of maxillary punctures in Brazil as part of the treatment?
No, no, we don't make punctures. No, not anymore. Just,
Okay.
the surgery.
Perfect. Okay.
We goes right to the surgery.
Beautiful. I had a quick question. Do you see also frequently polymicrobial cultures growing, which is expected in such forms of sinusitis? And does your microbiology differ from other countries, or it's similar across the globe?
No, we have another kind of bacteria, like Pseudomonas and Proteus and this kind of bacteria.
Perfect. And it remains mostly polymicrobial and mostly anaerobic, I guess.
Yes.
Beautiful. All right. As I don't see any further questions from the audience, thank you so much, Dr. Hammam, for your talk today. I'm going to go to my colleague. You're welcome. I'm going to go to Dr. Mutran to introduce our next speaker. Omer, back to you.
Okay, so next it is my pleasure to present Dr. Roger Mukarbel. Dr. Mukarbel is Associate Professor of Head and Neck Oncology and Reconstructive Surgery at AUB. He is triple fellowship trained in head and neck surgical oncology, microvascular reconstructive surgery, and facial plastic and reconstructive surgery. Has over 30 publications in his field, in peer-reviewed journals. He also has presentations nationally and internationally. Dr. Mukarbel is a fellow of the ACS, the AHNS, and of the Canadian Academy of Facial Plastics. He is also among the faculty surgeons for the AO Foundation and is a member of the Alpha Omega Alpha Honor Medical Society. Roger.
Thank you, Omer. Thank you for your presentation. I would like first to thank the organizing committee, ILMA, and Dr. Bakhash, who invited me to give this talk. I'll start by, do you see my screen? Okay.
Yes, Doctor, we see it.
I have no disclosures. So head and neck surgery is a diverse specialty. And this is attributed to the nature of the head and neck as a region and its impact on the quality of life of our patients. So when Joe asked me to give this presentation, I thought initially of selecting some of my reconstructive cases and maybe discuss free tissue transfer. After all, we like to show pictures as surgeons, and this field allowed us to operate on patients that were previously thought to be doomed. However, when I saw the initial announcement with the theme of the webinar, I noted the words update and innovation, which literally means making a new device. And it became clear to me which topic I'm to choose. Head and neck oncology as a specialty has evolved, but probably oropharyngeal cancer as a disease, it's the one thing that evolved tremendously and whose understanding and management has changed most during the past few years. It's a challenging disease in view of the anatomical complexity, its functional association with speech and swallowing, and due to the impact that it carries, not only because of the disease itself, but because of the treatment sometimes. While analyzing the data from the Surveillance, Epidemiology, and End Results database from the National Cancer Institute, note was made of a significant increase in the incidence of oropharyngeal cancer over the past few years. And in addition, we have been noting in clinic a change in the type of patient population of OPC that we see, from the time whereby we used to see smokers, alcoholics, and till to the time whereby we're seeing healthier non-smokers, non-alcoholic in the clinic presenting with OPC. All this suggested a shifting paradigm in risk factors and epidemiology and tumor behavior. And researchers started to look for a reason for this change in epidemiology and behavior. and whether there is a connection between head and neck oropharyngeal cancer and HPV. And then came the landmark paper by the group from Hopkins, led by Maura Gillison, who worked extensively on the association between HPV and oropharyngeal cancer. In their report, they looked at 200 patients, 100 with oropharyngeal cancer and 200 control subjects who were cancer-free. HPV testing was conducted, and note was made of HPV DNA in 72% of the tumor specimens, and 64% of the patients with cancer were seropositive for the HPV-16 oncoproteins E6 and E7, or both. And the association with oropharyngeal cancer increased significantly with the number of vaginal sex partners or oral sex partners, and was markedly elevated among patients with a high lifetime number of such partners. The association of HPV-16 was even more increased among patients without a history of smoking or drinking. That report confirmed that HPV infection is strongly associated with oropharyngeal cancer among subjects with or without the established risk factors of tobacco and alcohol use. And many more reports came confirming this association, and we came to the conclusion that HPV is the reason why we're seeing more and more healthier patients in the clinic with oropharyngeal cancer. HPV negatives are usually older with poorer health, poor oral hygiene, they're poorly educated, they're smokers, drinkers, while HPV positives, they're more like younger with good health, better educated, higher socioeconomic status, higher number of sexual partners, oral sex is in the histories, non-smokers, non-drinkers, etc. So this confirmed the association and the reason for the incidence. What about Lebanon? We have conducted at AUB a study of our population over the past 45 years of patients with oropharyngeal cancer. And this was a retrospective study doing PCR on historical specimens. And we found a similar association and prevalence in our own population of HPV positivity in patients who were diagnosed with OPC at our center. In addition, at the same time whereby we were seeing an increase in survival. And this was markedly significant over the past few years as well. So does HPV positivity confer a significant advantage towards an increased survival? The answer is yes. And this was confirmed through several clinical trials, RTOGO 129, Head Start, TAX 324, etc. They all confirmed a significant increase in the survival outcomes. So why is there an improved survival? Probably HPV positive tumors carry a unique carcinogenesis inherent to those tumors. There's an increased performance status and compliance of by the patients, and this is significant as well. In addition, those patients, the characterization that we see with other patients, and those patients who are HPV positive do have an increased sensitivity to RT. And other theories came about talking about reduced mutations, and this was confirmed as well through some papers. So we need to look at HPV positive oropharyngeal cancer basically as a different disease. In fact, it has different risk factors. There's a different clinical presentation with a lower T presentation and higher N staging. They're different histologically, and they have a better survival. And in addition, there's a unique opportunity that no other cancer in the head and neck has, which is to prevent disease through vaccination. So basically, it's a different entity. And subsequently, there came a need to look at the staging that we used. In fact, if HPV positive behaves differently, we should reflect that in the staging system. After all, staging was designed to help us, surgical oncologists and medical and radiation oncologists, to stratify our cases and allow proper communication between each other. And if we're to look at the benefit that HPV positive carries with it, we need to reflect that in we select the proper treatment. So in the newest edition, the AJCC 8th edition, this was reflected. Now HPV positive and HPV negatives are classified differently, different T staging and different N staging. And you can see that with the HPV positives, now we classify all our patients, most of our N patients as N1, even if they have more than one node and if the node is more than 3 centimeters. While we classify as N2 those with contralateral or bilateral disease, and N3 those with nodes larger than 6. And when looking at the TNN grouping to classify the final staging, we can see now that many patients in the HPV positive group can be classified as early stage, stage 1 or stage 2, while there are many ways for HPV negatives to get to advanced stage 3 and stage 4 disease. What about treatment? Treatment for oropharyngeal cancer can be surgical and non-surgical. Non-surgical through radiation or brachy or sequential, historically, or sequential chemo-RT or concurrent chemo-RT. All those treatments carry some toxicity to them. And our goal as oncologists and surgical oncologists is to find a balance between the treatment goals that we want to achieve and find a way to properly minimize the functional benefit that we will create, and also while keeping good outcomes as far as disease-free survival. Historically, open surgery was used, and there are many ways to access the oropharynx. All of them were considered as morbid with significant functional impairment post-op. In fact, for us to get good access to the oropharynx, we needed to do like a jaw split, a lip split, and resect the tumor, flaps, or trachs, long hospital stay, ICU, etc., and post-op morbidity that's significant if everything goes well. And we started to look at different ways to treat those patients. At the same time, more and more papers were confirming the advantage of chemoradiation therapy as a treatment for head and neck cancer, organ preservation in laryngeal cancer. And this was confirmed as well in oropharyngeal carcinoma through many randomized trials as well. In addition, studies showed that quality of life parameters were improved with chemoradiation therapy when compared to open surgery. So chemoradiation became more a la mode, and all patients were being sent for primary chemo-RT. As patients were receiving it, and as patients were surviving for a longer period of time, especially HPV positives, we started to note problems with the long-term effects of primary chemo-RT. In fact, patients would complain of xerostomia, pain, dysphagia. Some of them were PEG-dependent, some for life, skin problems, scarring, osteoradionecrosis on the long run. And in addition, we need to think of radiotherapy as a one-time shot. It's a one-time treatment. And it does increase the risk of second primary in some patients. In addition, many studies, for instance, Margaret study and MD Anderson group, they looked into this, and they found that the median time to return salvage surgery for oropharyngeal cancer patients with failed chemo-RT was 8 months for nearly 70% of salvage cases. So this is a highly morbid treatment, and that has a significant number of late toxicities. So we started as surgeons looking into a different way to treat those patients other than open surgery and other than chemo-RT, and started to look again to look into minimally invasive surgery transorally, and to see whether we're going to keep our oncological outcome, all while minimizing the functional impairment of our patients. At the same time, the Da Vinci robot was developed, and it was not designed initially to be used in head and neck. It was designed for abdominal surgery, but many surgeons, and mostly the group from UPenn, Greg Weinstein and Bert O'Malley, worked towards getting FDA approval for the robot to be used in transoral surgery. And our goal would be to minimize complications through this device and to optimize the outcome. The Da Vinci provides excellent visualization, 3D magnification, and stability for the surgeon's hand. And it has many applications in head and neck surgery, whether for resection of oropharyngeal cancer, laryngeal tumors, parapharyngeal, it can be used for neck dissections, facelifts, approach for thyroid, etc. And the term TORS was coined, transoral robotic surgery. TORS provides a minimally invasive way to access the oral cavity, no jaw split, no lip split, no pharyngotomy. There's a three-dimensional high-definition magnified view, great depth of field, primary filtration, and scaled motion. It provides simply a greater degree of freedom and allows us as surgeons to access areas that were previously difficult to access transorally. We can do side cuts, back cuts, rotation. There's no line of sight issue with the robot. Oncologically, it was equivalent to open surgery, and we'll talk about the studies in a bit. And it does achieve a lesser morbidity through a comprehensive approach. It allows us to maintain our oncological principles as surgeons of en bloc resections, to do a staged neck dissection or to do it at the same time according to the surgeon's preference. It will provide us with pathologic specimens that we're going to use to decide on the need and the choice of adjuvant therapy, which will be driven by pathology. The target would be to have our patients free of PEGs, no trachs, achieving lesser blood loss, lesser functional morbidity, and faster recovery. The exposure is achieved through specialized retractors. This is the Crowd-Davis retractor, and or the FK retractor. And we have a special room dedicated at AUB for the robot. We use it usually for this. And you can see that the robotic arms are introduced into the oral cavity, achieving excellent exposure. And we start dissecting. This is the patient shown from the picture. You can see how easily we can cut through the base of the tongue musculature. It can be used for resident teaching. A surgeon, an assistant surgeon, has to be at the head to assist with clipping and suction. And more papers started to come out confirming the oncological superiority, starting with the group from UPenn, which initially published their own series, smaller series, achieving excellent outcomes with minimal PEG dependency and excellent quality of life compared to chemo-RT. This is a paper from the group at UPenn, and they reported on a group of patients that only received transoral robotic surgery with nothing else, no radiation, no chemo. And they had a local control of 97%. So who would be a candidate for this treatment? We need to look at HPV positive patients. HPV positive cancer, they have a better survival. So it's those patients who are expected to live longer and to endure the side effects of their cancer treatment for a lifetime. So we need to develop treatment regimens that will achieve the same oncological outcomes, all while decreasing the morbidity. and hence the term treatment de-escalation for those patients. We need to reduce the incidence of late swallowing problems and to achieve reduced radiation-induced malignancies and problems. So who would receive surgery versus who would receive primary chemo-RT? For that, 3 questions need to be answered by the surgeon before considering transoral robotic surgery. First, can I get clear margins? Can I preserve function? And would my surgery reduce the dose of radiation or avoid the need for chemotherapy altogether? Basically, we need to stick to the least number of modalities. I'll finish with a few series before summarizing. Then beyond single institution series, we needed multi-institutional series and studies and clinical trials. This is a study, a multi-institutional study from 11 centers looking at 410 patients, showing a 2-year local regional control of 91.8% scores. And to note that around 40% of those patients avoided chemotherapy and radiation and were treated with surgery alone. And this is a study from MD Anderson looking at the quality of life, and they found that the patients who received TORS were 10 times less likely to receive it. Another major study looking at more than 2,000 patients lumped together from the National Cancer Database found a lower likelihood of post-surgical positive margins with TORS, and this is probably due to the higher magnification and precision of the robot and lower subsequent need for adjuvant therapy. What about higher level of evidence papers? This is a phase 2 study looking into purely HPV positive patients who were minimally smokers, like less than 10 pack years, that received significant de-escalation with only 30 grays in one arm with docetaxel and 36 grays in the other arm with docetaxel. And they found excellent outcomes, resulting in excellent tumor control and lower toxicity. I'll finish with 2 studies. This is the ORA study from my group in Ontario, and this is the highest level of evidence, randomized level 1 trial. They actually found that patients who received radiation therapy showed superior swallowing-related quality of life, but that was not clinically significant when compared to surgical TORS patients. However, to note that in that particular study, the number of patients was low, and many patients received triple modality with chemotherapy and radiation as well. And the surgical arm, many patients received the trach. So we need to remember that when looking into this paper. The final paper I'll discuss is the ECOG 3311. This is a clinical trial. The results came out last year, has 4 arms. They stratified patients into 4 groups, one that received TORS alone, one that received TORS followed by radiation therapy that's lower dose, and arm C included patients that received TORS with the standard dose IMRT, while arm D received all 3 treatments. And they found excellent survival for all arms, above 90%. For patients who were selected as low risk that received only TORS that were selected for observation, the disease-free survival was 93.9%. That's excellent. In addition, they noted excellent quality of the patients. So I'll finish with this. Oropharyngeal cancer has increased in incidence tremendously. It was driven by an HPV epidemic. Patients with HPV positive cancer do have improved outcomes, and this should be considered as a different disease entity. Hence, the staging has changed in the past couple of years. TORS has emerged as a most promising modality of the treatment for early stage disease, and TORS allows us to use pathologic analysis from the primary tumor and the neck dissection specimen to determine the need and the extent of adjuvant radiation and chemotherapy. And finally, we need to define through clinical trials the proper de-intensified treatment for those HPV positive patients to achieve improved swallowing and functional status after treatment. Thank you very much.
Thank you, Roger. I had the opportunity of listening to one of your presentations in Dubai a few years ago, and it's such a pleasure to listen to you again. So we have a question from the chat box. Dr. Roger, would you treat an HPV positive cancer of unknown primary with neck dissection or radiotherapy or both? And thank you for brilliant lecture from Sharbel Talani.
Okay. Thank you, Omer. Thank you very much. HPV positive unknown primary is a totally different entity, a totally different problem. So basically, the way I would treat HPV unknown primary now in 2021 is first to test the biopsy specimen for HPV. This is something that should be done for all unknown primaries. It's not the forum to discuss it, but I'll go over it quickly. The way I would do it is first try to identify the primary in unknown primaries. And most of these patients will be in the oropharynx. And we need to do tonsillectomy. We need to do a lingual tonsillectomy. We can use the robot for the lingual tonsillectomy. And we need to do that in a staged manner. Once we identify the primary, I would aim towards complete resection of the primary with negative margins, and I would use frozen section intra-op. And I would go for a neck dissection followed by adjuvant treatment in the same way that I would do for OPC in a manner whereby I would be looking at the specimen of the primary. If I have negative margins or positive margins, multiple node extracapsular extension, then in the next specimen, then I would consider a chemoradiation post-op. But if there's no extracapsular extension, it's a low risk patient, the tumor is all resected, then you could either select this patient for like a low dose radiation therapy or just observation after treatment. So unknown primary is a different ball game. It's different than OPC.
Thank you very much for that answer. That's exactly how we do it in Sweden nowadays. So just want to check if we do it right. Thank you, Roger.
Well, with pleasure, Chair.
All right. Omer, any final words before we move to the next speaker? Thank you so much, Dr. Mukarbil, for a great talk. I see no further questions from the audience. And as we move to the next speaker, I'm going to introduce Dr. Homer Mitran himself as our fourth speaker for today. Dr. Mitran is a dear friend. Our friendship goes 25 years now. He's an otolaryngologist, a physician executive, and an international speaker. He's currently the Associate Director of Otolaryngology and Head and Neck Surgery at Staten Island University Hospital in New York, and he also works at Lenox Hill Hospital in New York City. He's an assistant professor with Hofstra University, and he sits on the board of governors of the American Academy of Otolaryngology and Head and Neck Surgery as a consultant. His clinical interests are sinonasal function and cosmetic surgery. Welcome, Omer. Thank you for being with us. And I'm going to try to share your slides as promised.
Thank you, dear Francois, for the beautiful presentation. I'm always proud of our friendship and our history of sitting on the same, I would say, bench back in med school at USG.
All right, great, Omer. Thank you. Same here, same feelings. So can you see your slides?
Yes.
Beautiful. So I'm ready whenever you are.
Yes, I am ready. So you can go ahead and maximize it. All right, so I'm going to be talking today about steroid-eluting stents in chronic rhinosinusitis. I was asked to talk about advancements in ENT, and this is one of the fields that I feel is promising. We all know that there was in the past at least few years, there was a lot of new things in ENT. Some of them are promising, some of them are yet to show some proof. So I'm going to talk to you about this new thing that I personally started using a few years ago. Next slide, please. So I'm Omer Mutran. I graduated from USG and I started my residency actually at Hotel Dieu before coming to the US, doing my fellowships. And I'm still here in New York right now, practicing between Manhattan and Staten Island. Next, please. The definition of chronic rhinosinusitis has been more or less unchanged for the past 25 years, except for small tweakings here and there. So I'm showing here the ones from the clinical practice guidelines of the American Academy back in 2015, actually the update of that. This definition did not change in the most recent European position paper in 2020 or the more recent international consensus of rhinosinusitis from earlier this year. So it is 12 weeks or longer of 2 or more of the following symptoms: mucopurulent drainage, nasal congestion, obstruction blockage, facial pain, pressure, headache, decreased sense of smell. So 2 of these, the symptoms per se do not make the diagnosis, do not confirm the diagnosis of chronic sinusitis. We see that every day. A lot of patients come and say, you know, I just have sinusitis because I have pain. It's not really our topic, but these end up being a lot of times something else. So the symptoms are a high sensitivity, but a low specificity. To increase that specificity in diagnosis, we add an objective item, which is either an endoscopic finding of purulent mucus discharge in the middle meatus or elsewhere in the nasal cavity, or like a documentation endoscopically of polyps, edema, inflammation. The alternative to that objective item would be radiographic evidence, which is basically CT evidence of chronic sinusitis. Next slide, please. The current treatment of chronic rhinosinusitis relies primarily on medical treatment. So you can go ahead and click. You can actually click 4 times because, sorry, I had to have my friend Francois do that. I couldn't share my slides due to firewall problem. It's a new firewall they have here in the hospital. So it starts with medical treatment. Then once medical treatment becomes inefficient or stops working, or for some reason the patient stopped doing it, the next step would be surgery. Surgery, we will talk about what it does, but surgery basically is not a radical solution for chronic sinusitis. It helps to some extent to improve compliance, to improve delivery of medication, improve the symptoms of the patient, but it really relies on a post-surgical treatment to avoid a recurrence of these symptoms and to avoid the progression of whether polyps or inflammation. After that, we have to deal with, in a lot of times, with a recurrence, because this is a disease that does recur, and sometimes no matter what we do, it does recur. And then we'll start again with the aggressive medical treatment that would stop working possibly and lead into surgery again. This is how the circle continues. Next slide, please. So the goals of surgery, the surgery, as I said, is not a solution, does not cure rhinosinusitis. Surgery helps ventilating these sinuses by draining them and increasing the pathway of drainage. That's why we talk about functional endoscopic sinus surgery, which is going through the natural ostiums. It also helps us debride the inflamed tissue that can start an inflammatory reaction inside the nose. And it also provides access for topical therapies. That's what I explained to patients. It's piping. It's not a curing solution. It is piping to allow these medications to go inside and do the job. Next slide, please. The medical treatment relies on topical sprays, on medical irrigation that showed a better delivery of the drugs inside the nose, and on oral steroids that actually do work, but it's a short mode of action. So this medical treatment has limitations. Next. So the limitations include patient compliance, include a patient not being able to do the right technique to deliver the drug. You can imagine that you can tell a patient to use a nasal spray. Some patients would direct it to the septum, direct it to the outside. Some patients would do it more horizontal, more vertical. And there's a lot of variation that are not very accurate and would make this administration of medication not standardized in the way it's delivered to the patient's nose. A lot of times patients stop the medication because of some side effect, or sometimes there's no access to these medication, like if it's not covered by the insurance, or in some places, like right now, I would assume in Lebanon, there is a shortage of some of these drugs. Next slide, please. So this made researchers look for a better delivery of the drug inside the nose in a more systematic fashion, where you would allow for a better contact of these steroids with the inflamed tissue, whether it's polyps or inflamed mucosa. This is where these bioabsorbable polymers coated with mometazone were born. And these polymers would deliver locally the mometazone over 30 days by direct contact with the mucosa. And they do absorb, they do resorb within 30 to 45 days. So we don't even need to remove them. These devices were FDA approved to be used. They are being used right now in the maxillary frontal osteums and the ethmoids. Next step. So they are inserted through these pistons-like devices into the nose. They can have multiple shapes and multiple angulation of the devices. Just for example, you can see here that due to the frontal beak, the first image to the left needs more of an hourglass shape, when the one to the right, it needs more of a cylindrical shape. And these devices can be in multiple shapes. One of the early studies did show that this carried a relative reduction in the recurrence of the symptoms, whether it's a polyp patient or it's a chronic rhinosinusitis without polyps, significantly. And it was recommended based on this to use these post-op, immediately post-op at the end of the procedure into the patient's sinonasal cavity. Next. This is another study. This one is prospective, randomized, blinded, and intra-patient controlled, where they did draft 2 surgery on both sides of patients' frontal sinuses, and they used the stent only on one side. And they tried to compare back to back on the same patient. Next. So they had 2 different aspects of evaluation. One of them was by an independent reviewer, the other one by a clinical investigator. The first item, which is the need for postoperative intervention, is actually a dual endpoint that includes surgical intervention or oral steroid intervention. So they kind of took both possibilities as a kind of an item to compare. And we can see that this study showed a significant reduction in the occlusion and restenosis rate that was maintained at 90 days. Next. So this study also showed a relative 63% relative reduction in the rate of restenosis, corresponding to a 43% larger frontal sinus. So one more click, please, Francois. it would show how this difference in the evaluation of the diameter of the opening was seen just by putting this stent immediately in the post-op period. Next, please. So what about a recurrence of polyp away from the surgery? Let's say we do surgery, patient feels better, then years later, for example, the polyps do recur. What do we do to these? There is a newer implant now that is used inside, actually in the office. It is FDA approved to be used under local anesthesia. This one also releases mometasone, but it has a longer life inside the patient's nose, about 90 days. And again, you put it in contact with these polyps. The way the study was designed, they show that you don't even need to do an actual surgery. You just have to open it in the ethmoids. And they showed significant improvement in these in the symptoms of patients where they kind of delayed the surgery. Well, this is new. We don't have enough data yet over using it for years, but I think it is promising when it's used for the right indications. Next, please. This is an example of a patient where it was used. You can see the polyps, and then you can see the stent that was put inside. And this, the picture to the right was taken a while after putting the stent in, since it lasts for about 3 months. And you can see that the polyps have regressed from the first picture. Next, please. What about safety and complications? Well, there are complications, and there are local effects that we need to watch for, like bleeding, irritation, infection, perforation, whether due to the insertion procedure or due to the presence of the device of the foreign body inside the patient's nose. So this is something we need to disclose to the patients, and we need to watch for, because obviously nothing in medicine comes without any complications. Also, there is a risk of ocular effects. This is something to monitor, especially with patients who have intraocular high pressure or cataract. There was also a few cases of hypersensitivity, whether to the polymer product or to the mometasone. I know it's rare to have a hypersensitivity to steroids, but apparently in the literature it can happen. So it's also something to watch for. So in conclusion, this is a promising technology, but at the end of the day, it is delivering an old drug. It's not bringing a new drug. It's just showing a new way of delivering the drug into the nose. And I think when it's used for the right indication and on the right patients, it could help significantly in management of chronic sinusitis. It does contribute to a shifting of treatment. I don't know about the rest of the world, but at least in the US, ENT is tremendously moving to in-office procedures. A lot of what we used to do in the OR before, we are being kind of pushed to do it in the office. It would save a trip to the OR for the patient. It would be more timely efficient for the doctors. And the patient sometimes can go back to work the same day without missing any days, without going through general anesthesia. And this is one of the things we can do in the office under pure local anesthesia or even an oral sedation. The question I have is this making new generations of surgeons less good of surgeons? That means, is it making them remove less polyps and just rely on these devices? And maybe we'll have that answer in a few years, maybe in 10 or 15 years, when and if this is start being used more internationally. And we see that patients don't do the aggressive ethmoidectomy, the aggressive frontal sinusotomy, the draft surgeries anymore, like we train to do it and we are doing every day. Also, something to remember, this does carry safety and side effects risk. So keep that in our mind, and we need to make sure we have the right indications for these patients. Thank you.
Beautiful. Thank you so much, Omer, for a great talk. Very interesting indeed. If anybody in the audience has any questions, please feel free to unmute and ask the question to Dr. Moutran, or please share it in the chat box. Omer, I had a question when I reading about this as a very interesting device. Do we know what the long-term data shows about need for revision surgery? That's one question. And the other question is the limitation in the clinical evidence and the high cost for such a device, drug-eluting stent, steroids-eluting stent. Does it justify such a high cost procedure, and especially with the limited clinical evidence that we have about it?
Well, I'm going to start with the second question, and it's a very legit question. You can tell from the way this is. There's a little bit of resistance by insurance companies to approve these devices. This is getting a little bit better over the past couple of years, but at the beginning, insurance companies considered it investigational and kind of part of research. And it took them time to figure out that, yes, they are saving money, because it is to some extent, and if you take it on the globality of, thousands of patients, and saving 20 or 30% of trips to the OR and surgeries just by doing this and delaying kind of the surgical approach to these patients, and obviously not dealing with the potential complications, did make a difference. And right now the CMS and even most insurance companies kind of are changing that approach to see the value in this on their big studies. It did take them time. But I think this is a sign that, at least from a medical economic point of view, it might make a difference down the road. Now, regarding the first question, this was FDA approved back in 2011, but it wasn't put on the market until many years after. So we only have been using it for maybe 5-6 years. I don't know the exact timing, and we don't have that data yet on 10 or 15 years. But I think at some point we will have it. Whether it does do something bad, it is going to show something different in the future, what would keep us from using it, I'm not sure, but I don't think so, because steroids have been used in the nose for a long time, and this is just using steroids in the nose. But is it gonna, have any surprises? We haven't seen any red flags so far, but we're keeping our eyes open.
Beautiful. Thank you so much, Omer. Great presentation from Dr. Dawood. I'm going to go back to Dr. Yusuf Bakhash and Dr. Walid Ahmar to share a final word and to conclude the meeting. Thank you again, Dr. Ahmar and Dr. Bakhash, for having me and Dr. Mutran today for this webinar.
Thank you, Francois. I second also what Dr. Francois said, and thank you again for Dr. Bakhash, Dr. Ahmar, the ILMA Lebanese Order of Physicians, and to everyone who attended this webinar. It was a pleasure, and I'm looking forward for more collaboration in the future.
Thank you, Dr. Omer and Dr. Francois Fadil, for moderating these sessions, and thank you for all the speakers. Dr. Walid, if you want to have the floor before I share the slide for the next meeting.
Thank you very much, Dr. Bakhash. I must say the caliber of all 4 speakers was fantastic. It's excellent. As an interventional cardiologist myself, Homer, to know that you can use now stents in ENT as well, it was a novel thought and process. So all of them are fantastic. The caliber of the talks, I'm really proud of them all. I hope we all derived and learned a lot from all 4 speakers. And I thank you all for your time and all your efforts in preparing them. And I'll leave now the floor to Dr. Yusuf.
So I want to thank you again for your participation, for giving from your precious time. وبدي اتشكر كل المحتل اخذوا لحتى يقدروا يخدموا مجتمعنا الطبي، وخاصه انه نحن بلبنان عم نمرق هلا بوجودكم حدنا هيدا دعم معنا. وبالختام رح نعطيكم موعد بعد 3 نهار الأربعاء ب 15 كانون أول على الساعة 7. رح يكون عندنا المحاضرة الثالثة ورح تكون منظمة. Let me share my screen. ورح تكون منظمة مع الجمعية اللبنانية لأمراض الأطفال Lebanese Pediatric Association. أنا بدي أتشكر الكل وبدي لكم يعطيكم العافية وتصبحوا على خير.
وأنتم بخير ويعطيكم ألف عافية.
Thank you very much.
Thank you.
Thank you, Walid. Thank you, everybody.
Thank you, Yusuf. It was an excellent series. So we look forward to Halal Pediatric.
Allah Rad, in 3 weeks, inshallah.